since December of 2021, we've been hosting sessions monthly, the second Thursday, I apologize, of every month in order to cultivate trust and build relationship and get you acquainted with our research center. We are a research center. If you read your email, that is our mission, our purpose, and our goal. Not only is it our goal to ultimately find a cure for Alzheimer's, but we want to make sure the representation in those trials is there's equity in it. And so the hardest population to recruit, guess who? Men of color. So we have placed a special emphasis on building rapport, building trust, getting you acquainted with our coordinators, our interviewers, our clinicians. Come on in, sit anywhere you like. But our overall purpose is to help you age well, right? We're all getting older. Things start to, creak a little and you need a little bit additional support. So with that, we want to make sure you understand how your brain, your heart, your vascular, your all of your issues, whether it's joint issues or mental health issues, which is our topic today. We're going to be talking about all things related to mental health, which for men of color, we probably don't like to talk about as much, right? But today we're going to have an opportunity to have a dialogue and hear from Dr. Young. He's a psychiatrist here. He's a renowned psychiatrist and a man of color. So you have some cards on your table. If you have questions for him and you don't want to get up and stand up in front of the audience, that's fine. But if you do, we'll have a mic brought to you. Mr. Katie Bowe will be our moderator for our Q&A session. Again, we're going to keep doing this until you tell us this isn't what we want to do, right? So we encourage you to bring a friend along, bring a colleague, bring a family member, bring a neighbor. We're going to keep hosting these the second Thursday next month. We're thinking about having some live jazz music. So that's a consideration, but we take heed to your feedback in your folders, if you don't mind. Open those folders. There's several resources in there, but at the end, we ask you to complete a post-event survey. And then there's a huge bright yellow form in there. If you have not filled that out and you're interested in becoming a part of our research, you have to complete that form. That form gives us permission to contact you. And on the other side, there's some resources about mental health. So with that said, I'm going to get ready to turn the program over to Dr. Monica Parker. She's the director of our Outreach Recruitment and Engagement Core and our Minority Engagement Core. She's been doing this well over 2 decades. And so we wouldn't be here without her, but she is a board certified clinician. And unfortunately, she's not taking new patients. So what usually happens at programs, people say, hey, can you be my doctor? No, but she'll help you navigate to getting some good care. So without further ado, please welcome Dr. Monica Parker.
Hi, y'all. Thank you so much for coming out. Our crowd gets better and better all the time. So thank you all to the gentlemen who've been here before. Thank you to the gentleman who came out for the first time. Can I have you stand if you are one of our healthy brain participants or a research participant here at the Goizueta Alzheimer's Disease Research Center? Please stand. Okay, these are the noble warriors. Y'all need to give them a hand. Why? Because they believe enough in us to give us their biofluids, their cerebrospinal fluid, their blood, their intellect, but more importantly, their participation. So you represent a demographic that's highly sought after in clinical research, whether it's Alzheimer's, hypertension, infectious disease. I won't say I will say cancer, but we don't want to die from cancer. So our objective here is to help you with our minority men's discussion group. And that's not just African-American men. It's anybody who thinks of themselves as other. And part of what we have learned in healthcare is that we're going to have to be more aggressive and be our own advocates for healthcare, because just because a building is here, just because a doctor is here, doesn't necessarily mean that we're entitled to get care, receive care, or get care, because the way things are going, you're not going to. Okay. So you have to learn to be your own best advocate. So today, because of what the gentleman indicated that they are interested in, and I do appreciate that you all don't want to talk to females, and I'm not going to take over. I have some men who are supposed to be doing this, but in any event, what you have said that you wanted to learn more about health, how you can stay healthy, what kinds of resources are available for you. So these monthly discussions are specifically for men of color. Our objective is to give you insight into different disease processes, opportunities for you to participate in clinical research, whether it's Alzheimer's Disease Research Center, psychiatry, cardiovascular disease, or infectious disease. But more importantly, if you have a question in a specific healthcare topic area, we're going to bring you a speaker and provider. Today's topic, and one of the things that we've been asked to discuss and to address, are issues of mental health and stress and emotional wellness for people of color, particularly as it relates to men. So our presenter today, our expert, if you will, is Dr. Raymond Young. He's a psychiatrist, geriatric psychiatrist here at Emory University in the Department of Neurology. And he's going to talk about what he thinks is important for you to know. So at this time, I think we're going to have an exercise demonstration virtually with John. John's not here today because he is ill and unable to come out. But he usually is here and he really likes interacting with you. So we're going to start with a video of John. So turn around, move, make yourself move around, get some space. If you've been here before, you know what this means, right? So let's move. The thing that's nice about John Lewis's exercises, they begin in a chair. And you can do it in a chair. And if you feel like standing up, I think he gets happy and he says, okay, I want you to stand. So we want you to be happy. But the objective here is to introduce you to exercise. Exercise doesn't always have to be in a gym. Doesn't require that you get a lot of fancy equipment. You can do exercise in your chair. Mr. Tobias, you got us straight?
Welcome, welcome, welcome to the Emory Alzheimer's Disease Research Center. Hey, I'm John Lewis, and today we're going to get a little bit of that cardio in with a little bit of body sculpting. But all around the world, everyone asks me about your abs, the love handles, or the spare tire. I'm going to let you know it's 80% what you eat. So I'm going to show you how to body sculpt them. We're going to take our time, watch the motions, and we're going to learn a lot today. So let's get ready. In 5 seconds, let's get ready to go. Ooh, ooh, let's warm that body up. Ooh, ooh. Come on. Come on now. Okay. There we go. I want you to feel good now. Hey, hey. Come on.
abraza quien tú amas.
There we go.
More love, more hugs, more kisses.
Watch it.
Less war,
Watch
less
it.
greed,
Watch
that's what's
it.
missing. Todo problema tiene solución. True love, mucho amor, esa es mi religión. En lo grande que comienza la educación. Amar al prójimo sin condición en la lección. No tengas miedo, su dicha, sin miedo, blessing. Puede ser peor, el mundo está stressing. Muchos están sufriendo y no se lo merecen. Un mundo lleno pero de humanidad carece.
Y'all know I have to give you those abs. Let's get ready to go.
Up, you got 3 more minutes.
Set up. I need you to lean back. Three, 4, 5, 6, 7, 8, 9, and 10. Other side, nice motions. Hands up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Right leg over, hand in the middle. Go. 1, great. 2, 3, 4, 5, 6, 7, 8, 9, and 10. Whoa! Come on now. Chest up. Let's go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, lean back. Point your toe. And go. 1, 2, 3, 4, and 5. Switch sides. Point the toe. 1, 2, 3, 4, and 5. This leg wide. Point the toe. And we're gonna cross. 1, 2, 3, 4, 5. There we go. Open angle. Point the toe. And let's go. 1, 2, 3, 4, 5. There we go. We're gonna make a circle. Keep your knees bent. Hold on. 1, 2, 3, 4, and 5. Let's start off wide and circle in. Ready? Let's go. 1, 2, 3, 4, and 5. We're getting a little bit of them hip flexors too. All right. We're gonna lean. Knees up. 1, 2, 3, 4, and 5. Get a little bit of them quads. Here we go. 1, 2, 3, 4, 5. Let's go. 1, 2, 3, 4, 5. Let's go. 1, 2, 3, 4, 5. Let's go. 1, 2, 3, 4, 5. Here we go. 1, 2, 3, 5. Do it wide. Rock forward. Get that back. 2. 3. Go! Get him up! 5, 4, 3, 2, and 1. Great job, great job. I want to say to you, tell a friend every Tuesday at 2.
All right,
You
that's
not
how we
only gonna
start
get some
all of
good
our
information,
programs off. Thank you for participating. I hope you got a couple of tips that you can incorporate into your daily routine. Your heart rate's up. He's virtual. He literally is all over the country, but he definitely is here in person every Tuesday, every second Thursday with us. Okay, so Dr. Parker's already introduced Dr. Young. He's going to do a presentation here at the podium. Remember, write your questions down. We'll try to facilitate those. If you don't want to write them down, Mr. Katie Bowe is here to help facilitate our Q&A session. Thank you for being here.
Good morning, everybody. That was some nice exercise. I wasn't expecting that. All right, so thank you for inviting me, and thank you all for being here and doing this. I was asked to briefly discuss a little bit about anxiety and depression and the preservation of mental health in Black men. And because we only have 15 minutes, it's going to be a very brief review of anxiety and depression. And then I wanted to touch on a little bit of the barriers of some of the treatment to mental health for Black men, and then some of the solutions that have been going on out there as examples for that. And then I wanted to start off with just a personal insight, as a Black man myself, with our family. So this is my father. He's Dr. Raymond Young. He's a retired OBGYN. These pictures are of him getting his first hole-in-one after being a recreational golfer for 30 years. So he was super excited. And of course, he sent this to me and my brother very, very excitedly. And this was a very happy time for him. 5 years before this, our family's lives were turned upside down. In a period of 7 months, my mother and my younger sister both passed away, and both died due to complications unexpectedly related to lupus. My mother died of what's called an aortic dissection, which is a thinning of the aortic valve, and my sister was diagnosed with an undiagnosed cancer related to some of the treatment. So it flipped all of our lives upside down, but in particularly his, since he was very dependent on them emotionally, and he fell into a pretty deep depression and anxiety. He suffered symptoms of depressed mood, panic attacks, chest pain, palpitations, loss of weight, poor sleep, just overall just a poor lack of being able to function. And obviously we wanted to be able to get him some help. But as I found within our own family, there was some resistance to that within the family. And that's despite having a family history. His sister, he has a sister that had schizophrenia. He has a brother who had suffered from depression and a gambling addiction, but it really wasn't really discussed. It was kind of kept under wraps. And although not verbally talked, it was often within members of the family that depression and anxiety was seen as a sign of weakness. And although my father would never admit to it, he had a negative perception of what mental health was, even as a practicing physician. I did a combined internal medicine psychiatry training. And so as a result of that, he would often introduce me to people as an internist and not a psychiatrist. And it was my mother who had to remind him that I was a psychiatrist as well. So I don't know whether it was done intentionally or not, but he clearly had some kind of resistance to the whole idea of mental health. And initially he was very resistant to seeking any type of help. He would just kind of reach out to me because I was the psychiatrist, but I'm his son, so I can't take care of him in that sense. I was able to eventually convince him to do so. And even then we had some challenges because he wanted to find someone that he could really relate to. And that's very challenging sometimes as a Black man trying to find someone to do that. Ultimately, we were able to get him the help, and the result is, he's only one involved later. So it was good. So just briefly, in the United States, 13.4% of the US population identifies themselves as Black. In 2018, 16% of those reported themselves as having a mental illness, and that equates to about 7 million people. In 2020, this was actually increased in terms of the number of people identifying with having some form of mental illness or substance use. So over 8 million African Americans reported having mental illness or substance use. Over 5 million reported having an independent mental illness, and over 1 million reported having some form of serious mental illness. It's found that within the African American community, that 20% of us are more likely to experience some serious mental health problem compared to the general population. And then within our community, since 2008, there's been a steady rise in mental illness. And although overall rates compared to other ethnic groups are lower, suicide was the leading cause of death of young Black people from ages 15 to 24 in 2017. So anxiety and depression are very common within the United States. Women tend to report more than males, and that's just kind of the culturally how we tend not to communicate as much. Within the African American community, we see 1 in 4 African Americans are likely to experience some form of anxiety disorder. In the last couple of years, the rates of anxiety and depression have increased substantially, and some of this is thought related to a lot of the civil unrest that we've been dealing with, a lot of the police violence that we've been witnessing and seeing all over the internet. And of course, the coronavirus pandemic has been devastating to our community. All these things have contributed to increase in anxiety. These are some of the typical anxiety disorders that a mental health provider might treat. Social phobias are probably the most common anxiety seen in the African American community. For our youth, if they are a witness of violence, there's an increase of 25% chance that they will develop post-traumatic stress disorder. These are some of the common symptoms of anxiety. In addition to anxiety, one of the things is like physical symptoms, having palpitations, chest pain. I should say that during that time period, I developed myself anxiety and panic attacks after losing my mother and sister for a couple years. And the initial thought I was worried I was having a heart attack. I went to the ED a couple times until I was properly diagnosed and then provided treatment myself. And I myself had some resistance to treatment too, thinking I could get over it. But thankfully, I had a wife who was able to push me forward and move me forward. These are some of the common depressive disorders that we typically treat. Major depression, of course, is one of the most concerning ones that we can talk in more detail in the question and answers and stuff. These are some of the common symptoms of depression. Some of the common symptoms of depression overlapping anxiety, because anxiety is often a common symptom of depression. Once again, we have a lot of physical complaints as well. But in addition to that, you might have feelings of hopelessness, worthlessness, thoughts of death, and suicide as well. Some of the treatments of anxiety are things traditionally, such as medication therapy, usually the combination of medication and some form of psychotherapy, meaning some type of counseling or talking, are the most efficacious for both treatments of anxiety and depression. For more severe forms, you might include some type of inpatient hospitalization, or what we call a residential, like a day program, where people can go daily and get some treatment. For some treatment resistant, when they don't respond to those modalities, there are other things that we do. There's treatment called electroconvulsive therapy. People know it as shock treatment. It's actually a very efficacious and effective treatment that works well. Of course, there are other alternative treatments, such as acupuncture. And in terms of self-care, things that we can do are typical things like exercise, meditation, yoga, and of course, being finding community support to really kind of help us out. So these are some of the typical things that we do. Consequences of lack of treatment of anxiety and depression. Well, you can develop an additional comorbid psychiatric disorder. So like if you have primary anxiety, you can develop depression and vice versa. You can develop ongoing substance use, alcohol, illicit substances as you're using that. Rest those mood disorders. It can also contribute to the development of chronic medical conditions, developing obesity, diabetes, heart disease. These are all anxiety and depression or risk factors for developing these things. And as a consequence, you can develop dementia as a consequence of developing these other risk factors. And with the lack of proper treatment, anxiety and depression, we see an increase in mortality or death associated with these medical conditions. So for example, in patients with depression and anxiety, if they have heart disease, they're more likely to have increased mortality or a shorter lifespan than someone who does not have active depression and heart disease. Of course, there's a significant impact on work performance and the economy as well. Despite all these consequences, Black men were less likely to report feelings of anxiety, depression. Black men are less likely to use any mental health treatments. And as a consequence, depression tends to be more persistent and treatment resistant than compared to our white counterparts. This is just a small graph just kind of showing the reports of adults seeking mental health treatment in the United States. And what we see here is that the green refers to men and the blue refers to Black men compared to their white counterparts use mental health far less. We also see that within the Hispanic and the Asian. So what are some of the factors that are associated with mental health of Black men, how things are affected? Well, racism is a big factor in terms of that. Dealing with the onslaught of ongoing racism out in the community, also in terms of dealing with that in terms of medical health, having providers that may be overtly racial bias or have some form of unconscious bias, you're more likely to have a misdiagnosis. As Black men, we're more likely to be diagnosed with some type of psychotic disorder than some form of anxiety or depression. You're more likely to receive some type of forced treatment, some form of involuntary hospitalization or forced medication. And there's a perception from providers that we're less likely to be compliant as well. So these are things how racism affects that as well. From a poverty standpoint, we see more poverty within our community, and there's a lack of resources. And a result of that, we're less likely to have health insurance and unable to engage in the proper treatments. We're more likely to use like the emergency room to deal with psychiatric emergencies rather than actually going to see even a primary care provider or a psychiatrist. The stigma of mental health within our community, whether it's with the perception within ourselves that somehow seeing a psychiatrist somehow it's a sign of weakness, that it's not something that needs to be addressed, or it's something more of a faith-based that I need to get myself aligned and be more faithful. And sometimes we're not only stigmatized within ourselves, but within our community where there's a negative perception that if you go see somebody, somehow there's a weakness there. Lack of information, not being aware of programs like this to learn more about mental health so you can better take care of yourselves. The incarceration of rates, you're less likely to get any mental health treatment. There's bias in terms of when that you really, the believable that you have some form of mental health problem. There's a lack of transition of mental health once you've been freed. And overall, just a lack of social support. As African Americans, we deal with a lot more trauma, whether it's related specifically to, and often leads to a lot of other comorbid psychiatric illnesses, and just us not taking care of ourselves physically. This is Dr. David Satcher. He's the former Surgeon General of the United States. He's also the former president of Morehouse Medical College. He actually did a lot of research looking at healthcare disparities. He did a lot of publications at the Institute of Medicine. And he found that even though there was increased diversity in the United States, we saw a lot of adverse outcomes in terms of healthcare, and a lot of that had to do with kind of lack of diversity within the medical community. And so things that they identified were that there's within our community clear stigma of mental illness. There was a lack of trust in the community that somehow were being experimented on. There was a lack of cultural competence or cultural humility, meaning that the healthcare providers couldn't really relate or empathize with someone because of someone that was not like them. Lack of education and mental health awareness, and just overall, just a lack of providers. As it stands, there are, I think, like 41,000 psychiatrists nationally, and only 2% are Black. So it's extremely rare that you find someone of that. So some of the solutions that they identified in terms of trying to improve this was, one, to try to increase the number of Black mental health providers, to develop what we call cultural humility training of healthcare providers, to really advocate for clinical research dedicated to care of underrepresented minorities, like what's being done here, to develop more community outreach and education programs, and develop some innovative models of mental health treatment. So I'm going to touch on some brief examples of each of these. So the American Psychiatric Association has developed a program to try to increase the number of Black providers. And this is called the Workforce Inclusion Pipeline Program. And what they do here is that they try to identify undergraduates and try to expose them to the field of psychiatry, get them assigned to mentors within the field, work on resources for medical school preparation, help them prepare for medical school, and get them the financial support so they can participate in conferences on mental health, so they can learn more about the field, so they'd be more likely to be interested in that specialty as itself. Cultural humility training. This was developed by Dr. Melanie Teravon and Dr. Murray Garcia. They're out in California. Dr. Teravon is at the Children's Hospital in Oakland. Dr. Murray Garcia is at this. And they developed what's called cultural humility. And I'm saying this versus there's another concept that people might hear about called cultural competency. And the idea that you can be competent, understanding, identifying, and relating to someone else of a different culture. We don't use the term competency as much anymore because the thought is that culture is always changing. It's dynamic, and it's hard to ever truly be competent. So it's better to show humility and relate and understand that that you may have biases within yourself as a clinician, and try to be open to other people, and try to be able to be humble and kind of collaborate with the patient, and try to identify with them and relate to them in terms of their culture as well. This is an ongoing, continuous learning process, and then there's accountability associated with it. And Emory does a little bit of that training here. In terms of community outreach, there's a program called The Brother, You're on My Mind. This was developed as a collaboration of the Omega Psi Phi fraternity and the National Minority Health and Health Disparities. And it's in a way to try to collaborate efforts to educate Omega members and their families and related communities on the effects of depression and stress, and to communicate the importance of seeking help for mental health problems, to encourage affected individuals to get information. So what they do in this is that they provide a lot of education for with the Omega community about depression, and so they can be better teaching and advocate for the need for treatment, help them develop social outreach programs so they can advocate for that as well. The church is another avenue for individuals, since about 38% of African Americans that go to church are Black men, and there is evidence that as Black men, we still look to our church leadership as a sign of guidance, whether it's personal or spiritual and even psychological. And so the church has been doing that in some different programs and different theories. And what I listed are just 2 theories. I didn't want to get into real complicated aspects of it, but basically these theories are ways to try to help the pastors and the leadership kind of engage with the individual to help them address their emotional well-being and recognize that your emotional well-being is not in conflict with your spiritual well-being, that they can be related in some way, but they're not in direct conflict, because I think some people think there's a perception that they're somehow separate. And then the last one I wanted to talk about was an innovative program called the Confess Project, which is it's a cool project, and they refer to themselves as the America's first mental health barbershop movement. And their mission is to committed to building a culture of mental health for Black boys, men, and their families, through capacity building, advocacy, organizing, movement building. And basically, they train barbers to become mental health advocates. So, as you know, sitting in the barber's chair, you're going to be listening and talking to your barber about various things, personal things. And so they're not training them to be clinicians per se, but learning to identify issues that maybe come up and help their clients become more aware of mental health concerns and advocate for them to get involved in programs, getting involved in gaining access. They have 4-tier programs: access, advocacy, research, and innovation. Access, engage in the community to learn about what the resources are out there for Black men to get help, advocate for that help through community programs, not just within the barbershop, but going out into the community and the church and so forth, advocating for research like this program does here, really promoting that as well, and developing innovative styles. And they were started in Little Rock, Arkansas. I think their home base is here in Atlanta, but they've really built up and done a lot of good work, and they do receive mental health reward from the APA as a result of that. So it's a great program. What I have listed here is just a kind of a list of resources. So, we can always share this talk with people. And these are resources specifically for African Americans and Black men. Of course, within the Emory community, you can also go to with our outpatient programs here to give them help here too. But within this, we have a lot of resources specifically for Black men. So I would take people to take a look at those and kind of learn more about that. And that's it. I'd like to thank everybody for touching base. This is my dad and my son, and I'm thankful for programs like this because this helps our future. My son's part of that future, so I'm thankful for your participation. Thank you.
So I know we're going to open up for some questions here. I got a few myself, but let's just start from the back. My brother. All right, good. So the information given is going to be in the packets. Okay. Yes, sir.
Thank you for the information. Would love to hear your comments, even if general, on the cultural aspect of, let's say I got the blues. I want to have a drink of whiskey. And on Saturday night, I want to listen to some quality blues versus or comparing to anxiety and depression. Would you comment on that, please?
What kind of whiskey you got? Just wondering what kind of.
I should have said red wine in my case, but.
All right, man.
But you understand the comparison or the comments I'd love to hear.
Yeah, I think this is about being aware of being able to distinguish between things that within our culture that may be acceptable and helpful short term, having that drink, listening to some music. That's not necessarily something that is unusual or inappropriate, but knowing when the line changes and transitions over to this is abnormal, the persistent drinking every single day, the amount of drinking every single day, only drinking every single day, not relating to people, isolating yourself, not functioning. That's where you see the distinction. And so it's being able to identify and recognize the difference of that. I mean, I see working with patients that I have and recognizing that there are those differences and knowing that some things are normal and acceptable and just listen to it versus saying this is unacceptable. So I think we're educating, understanding the difference between that separation.
Let me ask you, everybody got questions and what have you. I'm gonna come to that, but real quick, by show of hands, how many of you remember the last time you cried? You cried. Tears, like tears. All right. Keep your hand up. All right. If it was this year, leave your hand up. If it was in the last month, leave your hands up. If it was today, leave your hands up. I need to talk to you. Who are you at? Because I need to make sure you all right. Okay. All right. That's good stuff. But I mean, I'm really proud of the fact that you guys know how to be in touch with your emotions enough to cry. Because there are a lot of people, and by, you ain't gotta raise your hand, but some people say, man, not only have I not cried, I only know if I can cry. And that's a thing. And we can talk about that too, but got some questions.
Yes. I don't really have a good primary care doctor. I had one before, but he got sick. So I'm a part of the Emory, is my healthcare services. I need a relatable healthcare physician because I went to one recently and I'm not going back because, we ain't on the same page. So are there any resources available through Emory that I can find somebody that I could actually relate to as far as our primary healthcare doctor goes?
That's good.
I'm going to answer that question for you. In some of the other discussions we've had, this seems to be a big problem, getting the primary care doctor that relates to you in the way that you want to be related to. So as a primary care doctor, I can tell you that you may be assigned to a specific healthcare group or group of providers in a group because that's what your insurance covers. But sometimes you have to go outside of what your insurance accepts and you need to be willing to pay that cost. Now I'm going to use Emory Healthcare as an example because that's your healthcare provider. There are other providers. The one that you got is probably not the best one for you, but within that network, there's probably somebody else. I don't think that there's an easy way to pick a primary care provider. I do know that the way we do insurance and the way we like to pay for our health and healthcare, it's dictated a lot of the times by what your insurance provider will cover. Some people are willing to pay extra to go outside of that system, and some people are not. But within the Emory healthcare system, within the WellStar system, within the Piedmont system, if you don't like the one you're with, there is another option. You just have to it's kind of like a hit and miss kind of thing. There's no easy remedy to fix it. You just need to find one that you like and stick with that one. And if he's outside the system, he's outside the system.
Let me dig into that, if you don't mind. Let me dig into that a little bit more, because I heard you say that last time. And I know that when I left the radio station and I had to get my own insurance, I ended up getting with a company and $1,800 a month or whatever it is. I don't go because I don't like them. So what I'm saying to you is that I feel what Zeke is saying. And as a man, to me, it's opportunity cost. What is it going to cost me more to go here and be offended and sometimes insulted by these people who I've had 3 of them within that situation?
Concierge medicine, MDVIP, it sounds like.
Okay, I'm not sure, but I'm saying for those of us who have limited time and what have you, it's like, yo, and in cases in which I need to go to someone, I just go to the urgent care down the street and just pay them. Because it's like, that is a valid issue. And I hear you saying, and it sounds simple the way you say it, but for us to go on that search again, first of all, hey, it's a blessing that I finally got the insurance. And if it wasn't for my wife and my kids, I probably wouldn't have had it. And
I think that that's a really good discussion point.
Yeah.
And I hear what you're saying, like, we're busy. Okay. I'm a physician. He's a physician. We don't necessarily have time to do that. But I think that one thing that you might do before you make an appointment with a doctor is, if you have certain questions about how you want to be, I'm going to use the word managed, or how you want to be addressed, call whatever that provider's office is or whatever that practice is and try to ask your questions. It's like, okay, if I need the doctor after hours, is there somebody who's going to talk to me after hours? Is there, what hospital do I go to if I have an emergency? Because the way healthcare is supposed to work is we're supposed to be responsive to you. And unfortunately, there is no easy, quick fix to that. I sprained my ankle. I'm resistant to going to the emergency room. So I sit there and wait until I can get an appointment with a provider. And you're right, it does take a lot of time, but I don't have an easy explanation. And I think that urgent cares exist for a reason. Although urgent cares are mini emergency rooms to me, they don't necessarily provide continuity. But if you broke a bone, you fell, you got a cut, you go to an urgent care. If you live in rural Georgia, you're going to go to whatever provider is available. That's likely a county emergency room. But there is no easy way to do it. I think you have to do a lot of your homework and ask your questions ahead of time. Emory has pictures of doctors. If you like the look of somebody, you can do that. But you have to kind of do a lot more work to pick a provider. It's not like it was when I was a little girl. We had one doctor in our community, and that's the one everybody went to. And if you didn't like him, you went to the university, that kind of thing. I don't have an easy answer for that question.
But it does feel good to know that you can now manage the expectation of thinking that it's easy. When you step up to the plate to do this, already know that, hey, this is going to be a bit complicated, but if I'm prepared for it, that makes the difference. Appreciate it. This is a great question, man. Next question.
Yes. How do we maintain our mental acuity as we age? And we're doing this, stave off mental illness. And my question is prompted by Supreme Court justices who seem mentally healthy and mentally sharp well into their 80s.
That's a question right there, man. I would say it again. Did you get it, Doc? I'm like, man, he might got it. I'm with you. I'm like, go ahead, Doc.
Yeah, thank you for that question. So, a lot of our mental acuity is impacted in part by our physical health as well as our social community. So part of maintaining your mental health is maintaining your physical health, for one. So that means having a proper diet, exercise regularly so you don't develop physical complications that can contribute to mental health problems. Also having the social support and the community support to allow you to continue to thrive and interact and engage in activities. I think people should never think that they should, when they retire, that they should stop engaging and stop learning and stop growing. You always have to keep your mind stimulated. When you don't do that, you atrophy. So you always have to grow. There is this saying that, the only way to grow is to put yourself in uncomfortable situations. And I think, even as we retire, we're always thinking, now we can finally rest. But the answer is, you got to continue to do that. To give an example, my grandmother, she's 101. And, she does it by staying active, staying engaged, whether it's being involved in her sorority or nowadays being involved in social media and all this stuff. So she stays engaged now and has still got her faculties. And part of that, of course, is some genetic blessings on top of it. So
it's good. That's a good question. That's a good question. My brother.
Yeah, I know this program is on anxiety and depression. Could you say a little bit about schizophrenia? Exactly what that is, diagnosis, treatment, and then also how you encourage person who is having some mental health issues to seek treatment.
Yeah, those are good questions. So schizophrenia is a condition that's considered what we call a thought disorder. And patients or people who develop this will experience changes in perception. So they may become paranoid. They may perceive everybody as being against them or conspiring against them. They may experience hallucinations. So they might hear things, that they perceive things, hear voices telling them to do stuff or not do stuff. Occasionally, they might be seeing things. and just overall become very disorganized. So this is something that we do see within all communities, our community as well. And it is a challenging condition because the person who generally has this diagnosis really has poor insight into that condition. They don't recognize it within themselves. So when everyone else sees it around them, they're not going to recognize it themselves. So some of the help in those cases comes with the trust of that family member. Ultimately, there might be times where you may have to force the issue. Your second question, how you engage someone? Yeah, a lot of that really comes a lot with how well you can connect with that person, how well you can talk to them, relate to them, provide some education. I mean, it can be challenging because I recognize that not everybody is very open to seeking mental health just for the things that I just talked about with some of the negative connotation, the signs that it's weakness or that I can do it myself, or I just need to go to a good church and I'll be fine and stuff like that. So a lot of it is a lot of education and just time and patience.
All right, cool. We got quite a few questions here.
Yeah, maybe I'm asking the wrong question, but for people that don't go to the doctor a lot and they paying the copay, I mean, the doctor bills, whatever, why is it that when they do go to the doctor, they still have to make a copay? You know, I mean,
The premiums, yeah.
right.
So you're paying the premium, you don't never go. For 5 years, you've been paying this premium. Why I got to pay now? Y'all ain't, yeah, okay, that's a good one, bro. Thank you.
That's healthcare, that's policy, that's government. That's completely out of my bailiwick. All I know is if you got insurance, they want you to pay a copay. Just like when you have car insurance, you got to pay that deductible in order for them to fix your car.
We don't care. We think that's something you can do. We're gonna be, yeah. Yeah, you need to run for president. There you go. Yeah, you can fix that.
I noticed you mentioned in the slide that there's a lack of following from African-American men, and that the church is one of the places where they're highly populated. Are you recruiting from Black churches?
What?
Black men for programs like this or any programs?
We are. In fact, we are connected with several groups. We're affiliated with, we have connections to the AME Church here in Georgia, the Episcopal District. We've been to Catholic churches. If you have a church that you'd like us to become interested with, please find Ms. Dorbin. But most of the men that you see in this room have come from a lot of the associations that we have made over the years. So we do engage with churches.
Good stuff.
Yes. In my family, we have a case of borderline personality disorder, which splashes over to a lot of thoughts of suicide in her case. Can you tell us a little bit about your experience with borderline personality disorder and whether you see it in a lot of people of color or any kind of statistics?
I'm coming to the east side next, y'all. I've got one more over here and I'm coming over there.
Oh, yeah. Hello. Yeah. So, good question. So for everybody, borderline disorder is a condition that's it's a little different than the mood anxiety disorders, although there's an overlap in that. It's a what we would call a character pathology, meaning this is kind of how people kind of navigate and go through life and how they interact with people. They have these specific constructs, and there's different types of personality disorders. A borderline person will often have extreme emotional ability. They go from being very angry, very sad, to be very happy. They have a hard time engaging in close relationships with people. Often they end up doing what's called splitting, where they identify with some people saying they're the greatest people and then other people are the enemy. And so they end up having a lot of poor relationships with people, tend to burn bridges. And because of that fragility, yeah, they often will have kind of injurious behavior, sometimes actually being suicidal. So yeah, they're very challenging. I can't speak on specific statistics. I mean, we do see this in all communities. We do see this within the African American community. There's this perception that you see it more so in women than you do in men, but I think that's a misperception. So I do think we see it in men as well, but they are a very challenging patient population. Not everybody does well in terms of managing patients like that. I don't consider myself to be really good with that population. I do okay, but some people are really good with it. So, yeah.
Mm-hmm.
Well, not necessarily. I mean, they might have some challenges with law enforcement and stuff like that. Unlike there's another personality they sort of call antisocial personality. Those are the individuals that really just see the world as their own and kind of follow their own laws, and they're the ones that end up in jail and stuff like that. Borderline personalities, they may push the law a little bit and stuff like that, but they're more likely to still follow the law. They may get in trouble in terms of workplace and relationships and stuff like that, but there's not as much legal trouble.
Good stuff. One more over here.
My question was, when and how do you notice the telltale signs of needing a therapist? Like some people don't deal well with grieving. Some people overthink, and things in that nature.
Good question.
Yeah, that is a good question. When you're, dealing with grief and loss and stuff, there is a point in time where there becomes a crossover where you actually need help. So a lot of it has to do with, what are the severity of the symptoms? How much has it impacted you? Where are you able to function? Are you able to go about your day? How are you eating? How are you sleeping? To the point where it's detrimental. How long has it been going? Anytime we go through any type of loss or grief, you're going to have some temporary periods of time where you don't feel like doing stuff, don't eat stuff. But when it becomes a prolonged period where it impacts relationships, impacts jobs, those are signs that you probably need help. You're starting thinking about, thoughts of not wanting to be here, thoughts of worthlessness, hopelessness being a big factor, not feeling like you have any way of getting out of this. That's a big one. And of course, suicidal thoughts as well.
Yeah, so thank you for doing this. This is amazing, by the way. So I read an article recently about there's a friendship recession in America, and men are suffering the worst from it. So and it talked about how most 1 in 5 single men do not have 6 close friends. And as a result of men not having as many friends, it increases loneliness. It's contributing to higher suicide rates, increase in violence, so on and so forth. So if you will, would you speak on men having a lack of friendships and having friendships, how all that can contribute to mental health struggles, but also how it can help us be better and healthier with our mental health?
Yeah, that's a good question. I mean, we do see that within our community with men versus women in terms of socialization and engagement. We're more likely to be isolated, and so that can be more challenging. I think a lot of it has to do with trying to get more engaged educationally, understanding what your needs are, and then making a point to advocate to get involved in communities where you can engage in those friendships. Find communities where you can do that. You can do that like in the church. Like I go to a church where we have a men's fellowship, so you can engage in a fellowship where you get engaged and identify and kind of interact and socialize and do those things. So there are a lot of community outreach areas where you can do those type of things.
Let me piggyback on that. So when we have friends, I've got a vast community, maybe 2 close friends. Does it make sense that let's say you have 5 friends or 4 friends. This one knows this percent. This one knows 25% that these don't know. This one knows 25% that these others don't know. Is that okay, or does close friends mean everybody know everything?
So, I think it's good to have close friends. I mean, there's nothing, I mean, numbers really shouldn't matter. I mean, if you have a few close people that you can relate to and someone that you can connect with and stay close to, I think that's important. I mean, I have, few close male friends that I'm connected with. These are guys that some Black friends I went through med school with, and we stay connected, and that's how we kind of connect. And so it's just a handful of us, it's what, 4 of us. And, that's how we do that. And all of us know a little bit of something else. And I think that's good enough. I don't think you need to have people be experts in everything.
Good stuff.
Okay, well, I have a question about Black culture and Black family life that is related to the fact that a lot of elderly Black men and women are taking care of their grandchildren, and they come up at 50 years old, and all of a sudden your life has been turned around because you're now a parent. And well, okay, but anyway, and then they find that their grandchildren that they are taking care of have been sometimes abused or undercared for when they're young, and their grandkids have mental problems. So it goes on that you're taking care of kids with mental problems, and you might even develop mental problems because your life has been turned upside down. And I even know of people who are taking care of their great-grandchildren, and there's problems with failures of families, single family homes, and that kind of thing that need support, and the grandparents step in. So that takes a lot of effort and love on the part of their grandchildren, their grandparents to do that.
Great question.
Yeah.
Yeah, that's a great question. I'd love to hear the answer to that
What I apologize, and I appreciate that statement, what you're telling me, that experience. What was the specific question related to that?
The question is there been studies, and do they have support for people who are grandparents who are in that situation?
Yeah, that's a good question. I'm not familiar with those studies. I'm sure there are studies that are related to that. So I'm sorry, I don't have that. And hopefully we can get that information to you specifically.
First of all, thanks for all of this. I've been trying to get with some of this for years. But in my family, I don't know if it's the same with everybody else, but we don't find out until relatives die what they've had because they don't swap medical stories at all. So me and my brothers, we basically share it with our kids to make sure we stop that. But in the meantime, dementia runs a lot in my family. And I wanted to know what you have to say about memory loss.
Yeah, I'm kind of getting into Dr. Law on this one too. I'm gonna hear from you on that as well.
Well, I mean, just from a mental health perspective, like think of what I was saying earlier, that with lack of emotional care and self-care, developing mental health conditions can contribute to complications of memory loss. Yes.
Father died, they die early. Matter of fact, my father died at 53 and he was in perfect health. He was in better health than me and I was in good health. And so his mother died in the early 60s. And so, and my father was an ex-football player. So I don't know if it getting hit too many times in the head or whatever, but anyway, it runs in the family deep and they're all in good health.
I'm going to take him off the hook for this one. In primary care, if you're 65 years of age and older, part of your annual wellness visit is you get a memory screen and you get a depression screen. And you also talk about those things that are inherited or traditional with families so that the doctor, who is your primary care doctor, can investigate those a little bit more closely. I will say that untreated depression and mental illness can look like dementia, but it is not necessarily. So for that, we have Dr. James Law, who can talk to you a little bit more about that, but you're a prime candidate for some of our Emory Healthy Brain stuff.
Well, I mean, there are so many things to touch on. You alluded to several things. But by the way, for those of you who I have not met before, my name is Jim Law. I'm a neurologist here, and I have the privilege of working with Dr. Young and Dr. Parker. I'm not Dr. Flowers, but I did sleep at a Holiday Inn Express last night.
That's good. I knew it was coming.
But anyway, you alluded to a couple of different things. One has to do with family history, strong family history of dementia. And that gets to be really complicated. But there are a lot of genetic factors that can predispose certain families to having more dementia. And then what you said about the former football player and repeated head injuries, that's a whole nother ball of wax too. And so there are a lot of different factors that can come into it, and we're trying to understand more across diverse populations what different genetic factors, different lifestyle environment factors, how that may impact our risk of developing Alzheimer's or other related dementias in later life.
You good? Okay. I want to ask a question about PTSD and the mental ramifications of that, because, you know, we may not have or know someone that has schizophrenia or some of these other things, but PTSD, yeah, I'm all up in that. So I'm sure a lot of people are, and I just kind of want to understand that space.
Yeah, good question. Yeah, as I alluded to in my presentation, that we see a lot of that, especially in our youth, that they're experiencing a lot of violence. And I think within our community, dealing with a lot of the racial unrest and a lot of trauma that we deal with, we do see that. So post-traumatic stress disorder is a type of anxiety disorder where a person develops symptoms of feeling anxious. They have difficulty in terms of how they relate to people. They startle easily. They avoid situations that are related to some type of traumatic event. And it's usually something that develops maybe after a month of the trauma that occurred. And the trauma can be anything, although it could be something that's directly that occurred to them, or it could be something that they've seen someone else experience, or as a community experience. I think people have developed PTSD, dealing with a lot of the traumas, I think people have developed PTSD, seeing what happened with George Floyd and other things like that as community, just really traumatic events. So people develop a lot of anxiety, and they can develop concurrently depression, and this can often lead to severity like suicide, and in substance use and other complications.
That's a whole different conversation. Yeah, we're gonna dig into that a little bit more, but
hey, thank you guys for enlightening us today. I appreciate that. My question stems from the distant relationship that's now formed with my mother as I've had kids. So my question more so like a CPR certification. Are there any programs out there that a normal citizen can walk in and just take so that we become aware of mental health disorders within our family or close friends, so that when we see something, not saying that we can diagnose someone, but if we see some behavior, we can tell them like, hey, I think you're experiencing X, Y, and Z. Here's a resource for you to go and reach out to. Because ever since I had kids, it's almost like the relationship between my mother and I has been severed, and I just need help with that.
Okay.
It's a great question.
That's a good question. And I do have, like in my talk that y'all can have at the end, I have a list of a number of different programs where you can learn about these type of things, where you can engage and do that. So there are resources where you can learn about mental health and how to talk about and advocate for that. So there's a list of those things. And so I have a multiple list that we can provide for you.
mental health mentallhealthfirstaid.com. Just Google mental health first aid. Uh-huh. That's good stuff, man. Thank you for that. Thank you.
Yeah, thank you for sharing that. That was great.
The problem, two-part question is that I've experienced mental breakdown in my family with my sons and other members of the family. And I had to get deep embedded into what was going on. And I saw the medication that they were using and how it kind of put them in a zombie form and stuff like that. So what I started to do was write down the doses and the different medication they was using. And some of these medication is just not good, but they keep using them over and over again. And when you see that, and you're not really, I'm not responsible for them in a sense where I can say, hey, I need to, for example, if you're not the husband, the wife, or a person that can vouch for them, they won't allow you to come in and say, hey, this medication is not working for him. So number one, how do you address a situation like that? And number two, when you have a different opinion on, if someone come to you and say, hey, this person need help this way, and your daughter say, no, it might be this way, where do you go so you guys can come together and come up with a solution?
Oh, that's a layered one there, brother.
Yeah, thank you for those questions. As a provider, I deal with those challenges, I think, a lot. When you have a person and you place them on a medication and there may be some questions about the side effects, what positive or negative impact they're actually having on the patient. So I appreciate you being an advocate for your family, because it is important to be able to determine whether or not what the treatment is that's being provided to your family is actually doing what it's intended to do, which the hope would be to improve their mental health and not cause more complications. And so you want to be able to recognize that. I think one of the challenges with that, of course, is just kind of recognizing what is like the potential diagnosis of the person, what the doctor is perceiving and what they think is the diagnosis versus what you as a family member might be seeing is different. And there might be where there is a disagreement and conflict with that. And that's sometimes as a provider, I do see that sometimes. And there may be something that there might be situations that you can work with somebody where you can say, okay, you're right. These are medications that are not good for this person. Let's try a different thing. Let's do a different avenue, because this is causing more problems. Then there are other situations where a clinician may say, well, unfortunately, this is really the best thing despite the complications, and really try to explain that. And so that's where kind of some of the crux or the challenge, at least from my perspective, that I see that. But yeah, I appreciate you advocating for your family. So you want to be able to do it. And I think it's always important, if you think it's absolutely necessary, to get a second opinion or some other person to kind of see whether or not this is treatment that is appropriate. As I mentioned, sometimes within our community, people are misdiagnosed all the time. So.
I'm sorry, I'd like to say thanks for coming out. The question I have deals with not having access or insurance to the care, but when you have insurance, you have a reference point, but when you go to be seen and get an appointment, especially with the brain center, there may be a year wait for you to get an appointment. And you have a brain problem, meaning you're wanting to have access, you want to get your brain evaluated, you want to have care, but your primary doctor has referred you to the neurologist or the specialty department with the brain center, but you call and they tell you, oh, it's a 9-month wait, it's a year out. Your first available appointment at the brain center may not be until 2023 in August.
Okay.
That's disheartening because
That really is. And part of the problem is there really aren't enough providers to answer the needs of the people that need the assistance. So there are two ways to address that. Would like Dr. Young to address it from the psychiatric illness part and Dr. Law to answer it from the neurologic part. It's supply and demand.
Yeah, unfortunately. Yeah, I mean, within the Emory community, there is overall still kind of a lack of providers. So we do struggle with that. I think what we do try to do is try to find what I would say community partners. So if our department is not able to get people in, we try to find people that we partner with in the community to try to get them access. We try to work with the primary care physician. If we're not able to actually provide the care directly, that we could actually provide some assistance. We have some programs within our department called kind of a e-consultation where we will provide some psychiatric support indirectly with the primary care person. So you may be seeing that person, may not have direct access to the mental health person, but that mental health person is providing you with some support. So there are some things that we've been trying to do to work around some of those challenges. But I mean, the bottom line is, we do need more providers. And I mean, within our community, we have a lot of work to do.
Is there a mental health crisis line that people can call if they have mental health illness?
Yes. So so there's the Georgia Crisis and Mental Health Line. So it's the number is 1-800-715-4225. And it's a good resource. They do two things. They can, if you're in a crisis, you can talk to them and they'll help you, and they'll even send a mental health person out to make sure you're doing okay and help facilitate some type of support if in an emergency. But they can also provide you with a number of community resources as well.
Thank you, Dr. Young. Dr. Law?
So I'm glad Dr. Young is here because the only clinical program that's harder to get an appointment in outside of cognitive neurology is psychiatry. But it really is a supply and demand issue. And the reason that you don't have more people doing dementia care or cognitive evaluations is you can't make any money doing it. All right. So if you're doing procedures and surgeries, insurance will reimburse out the wazoo. But if you're doing primary care, preventive care, or things that are time intensive and require, spending time with patients and families, there's no reimbursement for it. So we lose money every year. My clinical program loses a couple $100,000 a year, every year. And Emory Clinic continues to allow us to operate because we bring in other revenues from research to downstream radiology, and also we give the entire institution a better reputation because of how prominent we are. But that's why it's so hard to access that kind of care.
Great answer.
Yeah, I don't know how many people in here remember Jim Crow in the South. And we seem to be discussing on more than individual situations. As far as our group and our dynamic, as far as the guys, Black men, a lot of the energy been directed negatively to our community. Now, back in the day when you had Jim Crow, that was the control of us, because I was in here during this time. In the North, you didn't have Jim Crow. But they needed, as far as us not to accomplish, to disqualify. So as far as making a statement, I'll ask you a question too. Is it being looked at?
Okay, let me make sure I understand what your question is. Your question is, we had Jim Crow, separate system of this, that, and the other. But is there a certain amount of separatism, if you will, when it comes to administering mental health care to people of color? Is that your question?
Well, I've always been negative towards our community as far as influence and persuading. As far as, 'cause grandpa had the ability to run the country, but they had him out in the, as sharecropping. So it didn't have anything to do with his ability as learning and able to do, but he didn't have the opportunity.
Let me see if I can take a poke at that, because you're touching on something that is a topic of great interest. So when we talk about health and well-being and medical illness and longevity and disease, we often will talk about genetics. We may talk about, enzyme measures. We may talk about these very objective things that are easy to measure. Something that we're really interested in learning about now is something called social determinants of health. And so, and that includes everything. And so that includes, knowing you're going to get pulled over for DWB or shopping while black, or, all the things that you deal with, all the things that you encounter, whether it's, and it didn't go away with Jim Crow, it exists. So those things elevate your level of stress, and that is bad. Chronic elevated stress is bad. It increases hypertension. It may increase risk of other diseases over time. Where you live, what kind of exposure your neighborhood had to air pollution, noise pollution, access to quality food, access to healthcare, all those things, access to education, all of those things factor into these social determinants of health that we think have a major impact on virtually every disease. We just don't know yet what the impact is on conditions like Alzheimer's disease, late life depression, mental health disorders, but I can guarantee you that there's a significant impact. And so we need to learn how to define that, and learn how to quantify that, and learn how to alleviate the risk of people suffering more from those kinds of factors. Is that getting close to what you were talking about, sir? Okay.
Yeah. Okay. All right. You good?
He's good.
So if I want him to, I'm not aware, he's been trained. But if it's irritating him, he's gonna resist a little bit. But if he ease up and see that I'm not on his case, then he'll keep doing what I wanted to do. Okay, and in the community, if we not know we've been psyched out, okay, you have crime, us on each other. Okay, the system psyching us out, whereas we don't want to do it, but if we keep doing it, we won't be punished as much by attacking each other.
Thank you.
That's a little deeper.
Yeah. So who's helping people understand us? Mhm.
And you're a real passionate advocate for greater information. And one thing that we can do, and I'm going to have to move this along a little bit, is make sure that we identify persons of color who are doing this research. We have researchers at Georgia State. We have researchers at Emory. We have researchers at the Atlanta University Center who are doing psychological research, criminal research, all kinds of things. There are other people that are doing this kind of work. So at this point in time, Dr. Young, if you need to go, you're free to go. Dr. Law is going to take over and give us a little bit of a talk so you can get off the hot seat. Thank you, Dr. Young. Dr. Law is our clinical core director for our Goizueta Alzheimer's Disease Research Center. And because he and I have been working together for the last 12, 13 years, we're able to do more community educational programs. This is one of our programs for the last year, coming up on a year. It'll be a year next month. And we want people who are, I'll say, non-traditional or not in the majority part of the community, people of color, underrepresented minorities, anybody who's something other or mixed with European Americans, but otherwise thought to be not white. We want you to be a participant in our clinical research. We want to help you navigate the healthcare system so that you can get the healthcare needs addressed that you need addressed. But in this space, we are here for cognitive or brain health and for neurologic disorders. So Dr. Law.
Let me start by saying that I would encourage all of you, any of you, to participate in whatever type of research interests you, because there is a need to increase the diversity of our research participants in all areas of biomedical research. We're passionate about brain health and specifically about age-related diseases like Alzheimer's disease. And there are some things that you ought to understand. One is that African Americans have a substantially higher risk of developing age-related dementing illnesses, Alzheimer's disease and other dementing illnesses. Actually, before I say another word, I'm going to answer the question somebody always asks, and that's what's the difference between Alzheimer's disease and dementia? Alzheimer's disease does not mean that automatically you're laid up in a nursing home, okay? Alzheimer's is a very specific disease that's associated with specific changes inside your brain. It can lie there completely silent. Lots of people die with a brain full of Alzheimer's changes that never get sick, okay? Dementia, it just means that somebody has had decline in their thinking abilities that has impacted their functional abilities. And so that's all that means. And it can be mild or it can be severe. And people who have severe dementia may be totally incapacitated. They may be in skilled nursing. They may be in memory care. But that doesn't describe a disease. It describes a set of symptoms. Alzheimer's is the most common reason why older adults develop cognitive problems and dementia. And African Americans are at least 40 to 50% higher risk than Caucasians of developing Alzheimer's disease in later life. And it may be even substantially higher than that, maybe close to twofold. Hispanics are at higher risk. And so why is that? Well, when I was misanswering that gentleman's question, I think social determinants have something to do with it. Comorbidities have something to do with it. Genetics may have something to do with it. But the bottom line is, you know what? We don't know. We don't know why that is. And you know why we don't know why that is? Anybody? Why don't we know why Black folks are at higher risk? We ain't studied it. We ain't studied it. And so I'll give you a really stark example of this. And this was really infuriating. Anybody ever heard of aducanumab? Anybody in here interested in Alzheimer's disease and treatments for Alzheimer's disease? And you remember there was this controversy last year because FDA approved this drug called aducanumab, and everybody said that drug's going to cost $56,000 a year, and the evidence that it works is what? And so it was a pretty bad decision by the FDA, and that drug is basically dead in the water right now. But here's the part that was really amazing. So the data for that drug came from 2 huge studies. I don't know what they cost, hundreds of millions of dollars to do these studies. Each of them had 1,600 participants in them, okay? In both studies, each of them had 1,600 people. And the evidence that suggested this drug might be helpful came from people who were treated with the highest dose of the drug, 10 milligrams per kilogram per month. And out of both of those studies, you know how many African Americans received the highest dose of the drug out of 3,200 people? Come on, somebody give me a number. Well, come on, you got six out of all of those people. So what does that mean? So the company was arguing that this drug was showing evidence of slowing down Alzheimer's disease if you started in patients with very early stage disease. And they made that as a blanket statement. FDA didn't say, all right, we're going to approve this questionable drug, but you can only give it to white folks because that's the only people it was studied. And they didn't say that. They said you can give it to everybody. The risk of bleeding or swelling associated with this drug was up to 40%. 40%. Do we know if that risk is higher or lower in Black folks than in white folks? We have no damn idea. We know that in white folks, that risk is about 40%. That's all we know. So that, you know, that is a really stark example. in the last couple of years, with the disparities that was sort of exposed with the pandemic, with the PTSD that we all suffered from watching George Floyd get murdered, there's been a lot of attention to addressing these disparities because people are starting to recognize just how harmful this is. And we've been focused on this. Some of you all are new, and I hope that we get in front of you a lot of times. We've been in front of other communities, the partnerships that Dr. Parker has established with a number of the Black churches in the area, with AKA and some other sororities that we won't name, but Links and other African American organizations have been very supportive. We've been engaged long term since 2008. 2008. And so we know that in order to get people to engage with us and even participate in research with us, you have to know us and trust us and see us. I'm not going to show up at your church and ask you to give me blood and information and disappear for the next 20 years. That ain't going to happen. But we wanted to do this. We asked Reverend Bo here to help us out because we said, I said to Dr. Parker a while ago, I said, we've done great with Black women. In fact, since 2014 in our Alzheimer's Center, we've had exactly 50% African-American participants in our research. And this is real research. These folks come in, they have MRI scans, they give up blood, they do spinal taps, and half of our enrollees since 2014 have been Black. Of that half that are Black, I think about 85% are women. Women. So as we have success engaging with Black women, then the things that we learn, the things that we're studying, we can say, we have data and we have evidence that this applies to Black women. But what about the unicorns? What about you guys? We don't know. We don't know because we haven't engaged and we haven't studied. And so that's why we started doing this focused activity with Black men, because we want the results that come out of our work here to apply to everybody. We don't want it to only apply to some people or have this vacuum of knowledge so that we don't know if this is true for all people or only just for certain segments of the society. So that's why we're here. And the upside, before I kind of open up to questions for you guys, the upside is what's happening in the Alzheimer's space is incredibly exciting. Back over 20, actually going on 25 years ago now, one of my social workers was doing a support group and she overheard a conversation that's still one of my favorites. So one of my patients, two ladies were talking, and one of my patients says to the other patient, she said, Dr. Law says there's going to be a cure for Alzheimer's disease before he retires. And the other lady says, yeah, don't you wish he was older? That was 25 years ago. And people thought I was crazy when I said that back then. I'm more convinced of it now than I was 25 years ago. And I think the evidence proves that. This coming year, in 2023, there will be a new drug for Alzheimer's disease, and it will not be like the drugs that currently exist. It will be a drug that actually impacts the course of disease. And what do I mean by that? What I mean by that is Alzheimer's disease is maybe when people develop problems from Alzheimer's disease, they have disease that's lying dormant, silent in their brains and changing over time over 15 to 20 years. And then when symptoms first start, people may have just some lapses in memory. It's hard to even tell whether it's normal aging or not, but then the memory problems may get gradually worse, may spill over into other abilities, and eventually goes from what we call mild cognitive impairment to mild dementia to moderate dementia to severe dementia to terminal dementia. That process, on average, takes about 12 to 15 years. Okay, and that silent period, I said, is 15 to 20 years. So we're talking about a 30-year disease process. The drugs that we currently have may provide a little bit of a boost in terms of your symptoms. If you're going downhill like this, may give you a boost, but that curve is exactly the same. It doesn't shift one bit with the current drugs that we have. What these new drugs are promising is they're going to take that 15-year course and maybe stretch that out to 17 years or 18 years or 20 years or 25 years. And what that means is because most people get Alzheimer's disease when they're in their 70s and 80s, that means the more it's drawn out, the better chance you got of getting run over by a bus before you're incapacitated. Okay. And that's coming. That's coming this year. It is going to get approved. CMS is going to approve it. Insurance is going to pay for it. And only people who are recognized and diagnosed early are going to benefit from it. So we have a lot of challenges here, right? So we want to be able to recognize disease earlier. Black folks get diagnosed with Alzheimer's and other dementias about, on average, 4 years or more later than white folks. That's a bigger problem tomorrow than it is today, because if a Black patient is not getting diagnosed until they're past the point where they're going to benefit from these drugs, they will have lost the opportunity to have benefited from those drugs. So that's where the situation is now.
Cure are absolutely fascinating. And you're talking about Alzheimer's. Do you have information about predictions for cures of other mental illness?
Well, I don't, because that is not, that's, you know, I can't, if I can make some contribution to this disease and preventing this disease, I will consider my life to have been well spent. It is. It is. So there is something called precision medicine or personalized medicine that you might have heard about. And what we're doing is, you know, I said this treatment's going to be available next year, right? That's not enough, because it's not going to prevent people from getting sick, but it's the first step. But what we really need is to be able to figure out who's going to get sick and when they need treatment, so we can prevent them from getting sick. And that's the whole idea of preventive, personalized medicine for prevention. And that can apply to any area. And the reason we're able to do this now is because the technology has developed to a point that we can study things and come up with patterns and learn patterns about proteins and testing and everything else that we never could have done before. So it's coming. I promise you it's coming. And what we want to do in our work here is to make sure that what we're studying in terms of learning about Alzheimer's disease and preventing and predicting Alzheimer's disease will apply to a diverse population of individuals.
Got one question, Dr. Law.
Yes, I have a question. This new class of drugs, will they be available through a primary care physician, or must a person go to a specialist?
In all likelihood, the prescribing authority is going to be restricted because like I said, this drug is going to be similar. We haven't seen the data yet. It's going to be presented next month out in San Francisco. It hasn't been published or anything. They just released, the company released a press release. But even with this drug in their top line results, 20% of individuals who are in these trials develop problems with microscopic bleeding and swelling. Now, if those things are managed properly, it can be safely managed, and people usually don't even have any symptoms. But you have to know that's going on and hold the medication so that people don't get sick. You also have to know who to treat. And so, you know, people who get diagnosed these days, they're given a diagnosis of memory loss, dementia. They're never told they have early stage symptoms of Alzheimer's disease. That doesn't happen. 80% of the time, that just doesn't happen. So it is only going to be applicable to people who have Alzheimer's changes in their brain. Otherwise, you're exposing people to risk and cost that's going to do them no good whatsoever. So that's, but it's a big step forward.
Are there any foodborne contaminants or things we should avoid, like certain mercuries, minerals, aluminums, that can kind of slow it down, or kind of something we should alleviate?
We definitely don't be eating no mercury, brother.
I mean, you know, well, it's in the, when you're eating fish, like, you know, especially like farm raised fish and salmon and stuff like that, then you incur those types of substances. So
Well, that's, you know, it's actually not a joking matter, because in the Midwest, in the Great Lakes area, mercury contamination has been a significant problem in fish. You know, aluminum got a big publicity, you know, blowout years and years ago, but Coca-Cola lives in Atlanta, Georgia, and we ain't going to be talking about aluminum. And that's been mostly debunked anyway, as far as causing Alzheimer's disease. Environmental exposures like toxins or metals really have not been strongly associated with Alzheimer's. It's been more strongly associated with Parkinson's disease. So certain pesticides and environmental toxins, PCBs, may have a stronger association with Parkinson's, but not so much with Alzheimer's. For Alzheimer's disease, the two biggest risk factors are age, far and away the biggest one, and family history, because we know there's a significant genetic component. The environmental factors play an important role: head injury, you know, sedentary lifestyle, obesity, heart disease, hypertension, poor diets. You know, in terms of diet, we generally recommend that everybody. I wasn't looking carefully to see what they fed you guys today, but chicken, but high vegetable content, fresh vegetables and fruits. There you go, back there, nuts and whole grains. That tends to, as opposed to highly processed fats and sugars, it tends to be more of an anti-inflammatory diet. And so it promotes healthier aging, healthier heart function, and healthier brain function.
We have one question. That's going to be the last one. And then
Okay.
got to get out of here by 1 because it's security.
Yeah, I think you partially answered it. I had a short experience because my mom, for one instant, and it was just a second, she forgot who I was, and it scared the living daylights out of me. And I walked up to the table where she was at, and she was like, "Well, I'm waiting for somebody," and it was me, and it's only her and I. So she's in a whole nother state. My question is, what's the maybe top 2 activities that a person could do to help offset or slow down Alzheimer's or dementia?
Great question. And I'm glad that's my last question I get to answer. So one is aerobic fitness. Okay. So aerobic exercise has a whole host of positive benefits for your body, but it also has a significant benefit in promoting healthy brain aging. So sedentary lifestyles are bad. And making sure that you get some aerobic exercise, at least 30 minutes, 5 days a week, of something that's going to get your heart rate and respirations up. And, you know, my mom's 87 now, and she got really ticked off when she got hurt, but then she jumped in the pool, and she's been doing that every day. So aerobic fitness. And then the second thing is something that my PhD is in cell biology and molecular genetics, right? So I'm a hard science kind of guy. But I have become an absolute believer in something called cognitive resiliency. And the things that can help to promote that, one of the really important things is to continue to have activities that keep you having a good, strong sense of purpose in life. So, people who retire, I worry about them because, what are you going to do for stimulation with social activities, challenging your mind? But if you're going to retire and then you're going to pursue something that really means something to you, contributing something to your community, to doing something that is for the betterment of the world, those things that really have meaning to you, that appears to really promote that resiliency. And there's even genetic associations with that. And so continuing to stay mentally and socially engaged, social isolation, I thought about this when Dr. Young was speaking. Social isolation in late life is one of those preventable contributors to dementia, Alzheimer's, and other dementia. So exercise, stay active mentally and socially, and do something that has meaning for you. I don't really care what it is, but do something that makes you feel like you're still engaged and have a reason for being there. Okay, so Julius is up, and he's going to tell you about research.
So good afternoon, everybody. How y'all feeling? All right. So I'm Julius Powell. I'm a research coordinator with the Emory Healthy Brain Study. I've been with the study for about a year at this point, and one of our consistent challenges is recruiting African-American men. In fact, as of yesterday, I've had my third Black male participant in the study in about a year. So that says a lot, right? Given one, we're in Atlanta. This is the Black epicenter of America, right? So Black culture, Black research, Black medicine. So if you can imagine someone else in my position in another state, that number is probably lower, right? And it's pretty alarming given that as African Americans, we're twice as likely to be affected by this disease. So we are twice as likely to be affected by this disease, but we are not twice as involved in the research to potentially cure this disease. So what does that translate to? That translates to 50, 60, 80, 100 years down the line, when it's potentially your children, your grandchildren, your great-grandchildren, when they're potentially dealing with this disease, you know, the medications of that time, the information of that time, that's not going to be for them, okay? That's not going to benefit them, okay? They're going to have the same tools to fight Alzheimer's then that we have now, okay? So it is extremely imperative that as African-American men, we start to represent ourselves in research because it's for the future, okay? So with that being said, I want to talk to you all about a wonderful opportunity to get involved with research, and that's with the Emory Healthy Brain Study. So what is the Emory Healthy Brain Study? The Emory Healthy Brain Study is an observational longitudinal research study. What does that mean? That means we're going to work with you for an extended period of time, get some information, and with that information, we look for changes in the body that can be indicative of Alzheimer's or other dementia onset. Okay, so how does that work? What do we want from you? So we're going to ask you to come in once every 2 years. We do a mix of data collection and testing. With that information, we look for changes in the body that are indicative of Alzheimer's and other dementia onsets. And with that information, what we want to do is eventually cure Alzheimer's. I think that's the overall goal, okay? But if we can prolong onset or just get some better quality information in regards to this disease to just better equip ourselves to fight it, that's what we're going to do, okay? So a few things I want to say in regards to the study. One, this is not a clinical trial study. So we are not trying any drugs on you. You're not going to be a guinea pig, so you don't have to worry about that, okay? And also, with some of the testing that we do. So for example, we do an MRI, we do an EKG, we do some vascular assessments. If we find something out of the ordinary, so elevated blood pressure or abnormal heartbeat, we're gonna let you know. And that'll be a conversation that you can have with your primary care physician. So what is that? That's potentially preventative, right? That's being proactive. That's the first step, you know, getting it before it gets you, right? You know, in our community, we hear it so often, you know, if we would have known 2 weeks before, if we would have known a week before, a day before, oh my God, we could have caught it. You know, we could have did so much, you know. So with the Emory Healthy Brain Study, this is that potential, you know, 2-week notice, that potential 1-day notice. You know, this is potentially life-saving, okay? So who are we looking for? We're looking for participants aged 50 to 75 with no mild cognitive impairments or other dementias, okay? So if you all are interested in joining or maybe seeing if you're eligible, if you want to fill out those yellow sheets in the pamphlet, someone will get back to you either via call or email. If you want to talk to me, I'm glad to answer whatever questions I can. Again, I'm a research coordinator, so I do the in-clinic and the cognitive testing component of the study. So any questions you have about that process, please let me know. I'm glad to answer. But with that being said, okay, a few questions. Okay, all right.
I heard that if you did CT scans, you could find proteins in the brain that might contribute to either one of those dementia or Alzheimer's. Would you be doing that in your testing?
The CT scan, no, we don't. I'm gonna let Dr. Lai handle this one, actually.
No. So MRI scans and CT scans you can see things as small as about 1 millimeter in diameter. But Alzheimer's disease, if we were going to look for that in your brain, we'd have to take a piece of it out and look at it under a microscope, and people usually aren't too keen about doing that. One thing that that didn't come up, and you're going to tell them about the other stuff that they're asked to do, right?
Well, so I guess if you want me to was that what you're asking? You want me to break down the in-clinic component? Okay, so when when we do a cognitive assessment or a cognitive test, that's via teletest, that's over Zoom. If you all want to come in, you can do that as well. With the in-clinic component, so we do an MRI, we do an EKG, we do your vitals, we do a blood draw, we do a spinal tap. That's kind of what so the spinal tap, a lot of apprehension in regards to that generally, right? And let me just say, I have not gotten a spinal tap, so it's only so much I can talk about. But from my observation, so I'm in the room when people get these. I'm going to talk to you the next day after you get it just to make sure everything is smooth. Generally, the numbing is the most uncomfortable part. After that, conversation, you get the conversation going, they got the fluid. When I call them in the next 24 hours to make sure everything is good, generally it's, well, my back is a little sore, but that's it. I'm feeling okay. I'll say, well, take a Tylenol. Well, it's not really Tylenol sore. It's just a little, and I can tell, something happened, but I'm okay. So don't be too afraid of that spinal tap. It's not as bad as it seems.
And right here, we have Mr. Sampson, who has had a spinal tap and is in one of our studies. Mr. Sampson.
Yes, it's a spinal tap. There's really nothing to it. You're just laying down and get the little needle in you, and I feel good. And didn't need any type of pain medication and nothing. So
Did you drive home right after?
right after.
All right.
There you go. All right. Well, with that being said, I thank you all for your time. Any questions? Any other? Oh, my bad. So for one, I'm sorry, I don't want me to cut you off, but so for one, spread the word. Two, again, filling out those yellow sheets, because if you aren't eligible for this study, we're going to see if there are other studies that you are eligible for. I think that's pretty it. Something else I was thinking about. Oh, excuse me, yes, with the healthy aging. So 18 and up. So yeah, that's like a database study. So we're just looking at your questionnaire only, right? So if you want to join that and we can see if you're eligible for other studies, go ahead and do that. All right. You need a So we're going to ask you to come in once every 2 years. That's it. Once every 2 years. Yep. Oh.
All right, everyone. I'm the last speaker. My name is Tanya Mletsko. I am a program manager in the Department of Psychiatry. And so we also have some current studies going on. Especially I think Dr. Young talked a little bit about depression and PTSD. So we have 3 studies currently going on. One in depression is the psychedelics. So there's a big hype in psychiatry about using magic mushrooms now for treatment in depression. And so Emory's at the forefront of that. We have a Center for Psychedelics and Spirituality. And so we have the upcoming COMP 005 study in which we are using 25 milligrams of psilocybin in the treatment of resistant depression. So that's a study that we are very, very excited about. And so maybe that's a cure, like Dr. La was talking about, a cure for neurology. We're hoping that in psychiatry, psychedelics can be something similar. And so I'm going to talk about that one right now. So it's a clinical phase 3 trial, which means that has been tested in healthy adults before. It has been tested in adults before that have depression, but now it's going to be a broader spectrum, more people to see whether it actually is efficacious. It helps, and we're still using a placebo. So it's a one-time administration. where you get psilocybin and you have therapy right beforehand, during, and after. So you don't get any medicine other than the psilocybin, and you're staying with us for about 12 to 16 weeks. So Emory is the only site in the southeastern US, one of 6 in the US and one of 12 globally. The randomization, and I'm sure Dr. Parker has talked about that in the past, if you've been here in the past, is we always use placebo as a control, but your randomization is 2 to 1. So you have a 66% chance of receiving psilocybin. All right, so then all you need to do is you need to be older than 18. You must have failed 2 to 4 different antidepressants in the current episode. I'm just writing it down there. It's you can contact us and we will go through a little bit of a screener. And then we have a study also of psilocybin in palliative care with demoralized cancer survivors. So if you know somebody who has had cancer, and deals with chronic pain and demoralization, so hopelessness. We have a study that's specific for Emory, only at Emory, where 10 patients will get psilocybin. It's a phase 1 non-randomized open label pilot study. So we are really, really excited about that, since that is our first study in the Emory Center for Psychedelics and Spirituality. All right, somebody talked about PTSD. So we do have a study about a PTSD or for PTSD where we're testing a new compound. A compound is always something that is not been marketed yet by the FDA or not been approved yet by the FDA. So we don't have a brand name for it. Okay, so we call it a compound. This compound is BI 1358894. It's a phase 2 trial. You can always go to clinicaltrials.gov and look that up, but it's a very new drug that has never been tested before and never been approved before. And it is supposed to decrease your reactivity to or emotional reactivity. So it's supposed to help with affective instability, like in PTSD and MDD and in borderline personality disorder. So it's supposed to reduce your stressor, your response to the stressor. All right. So I know Dr. Young talked about it a little bit, but I wanted to get into it in more depth. So in Georgia, your chance of getting quality mental health care is very scarce. We are the last one in the nation. All right. There is recent legislation that was aimed at increasing access, but we don't have enough practitioners. So there is some areas, if you're still in employment, you can ask whether they have some free access for you, but this is just a little bit of a chart to show you how difficult it is in Georgia to get mental health care. But this is the number. If anything you take out from my like 5 to 10 minutes in Dr. Young's talk, is call this number 1-800-715-4225. They are staffed 24/7 with counselors and social workers. They will get you an appointment close to you. They will have a mobile crisis response service that come to you for de-escalation, for on-site crisis management. It's free of charge. It's the only one in the Southeast. So this is specific to Georgia. Georgia Crisis and Access Line is your go-to phone number, all right? So if you're interested in psychological help, okay, but you're not ready yet to pay money for a practitioner, or it takes you 9 to 12 months to see one, then there are several resources where you can actually read up upon how can I find more about depression, about anxiety, about OCD, about social phobias. The top one is actually based out of Australia, and they charge you $59 to do this course, and it's CBT online course. There's some really good information about coming from the UK. It's called this at mind.org, and then there's also This Way Up. So they have a good depression program if you're interested in looking into that, but you're not quite ready to talk to somebody or you can't get in. So financial support resources are always there. In this slide, you will get online, or it will be sent out to you, and that is irrespective of mental health, okay? There's always patient assistance programs that you can get help from, and so I just put that down there. Clinicaltrials.gov, if you're interested in research and you have a disease that you want to look at, you can either go to clinicaltrials.gov if you're anywhere in the country, or you can go to clinicaltrials.emory.edu if you're in Atlanta. And we at Emory have about 1,200 clinical trials going on all across the disciplines. You know, there's going to be 20 to 30 in Alzheimer's. There's going to be 10 to 20 in psychiatry. And so there's going to be a lot in cardiology. So for anyone, if you have somebody who says, oh, I have, you know, high blood pressure and I can't afford the medication, there's going to be a cardiovascular study for you. All this information as well is going to be in your handout. But if you just want to have, Chris 180 is very good for children or families who need some mental health resources. The Depression Bipolar Support Alliance has free group session if you're interested, or if somebody you know has depression bipolar disorder. There's NAMI, the National Alliance on Mental Illness. There's the DeKalb County and Fulton County Service Boards. DeKalb County has 20 locations in DeKalb County where you can get free or reduced fee services. Chaplains in your community, Dr. Young already talked about it. We used to refer a lot to metropolitan counseling services, but I checked today and the website was down. So that was not very good. But if you want to get in contact with psychiatry or specifically with me in the Mood and Anxiety Disorders program, I have the privilege of having the most easy email address, which is study@emory.edu. We've had it for years. So, and then you can call us at 44778-MOOD, that's MOOD, or 6663. All right.
Tanya gave us a whole lot of information, and write those numbers down for resources for family members. And I'm not supposed to say this, but I am going to say this. Unlike other studies that involve people of color, if we find something that is wrong or abnormal, we're going to make sure that you know that it's abnormal and make sure that you get to the proper places to get those abnormalities addressed. We're not going to leave you hanging there just because you participated in research. And the reason Dr. Law is here, the reason Dr. Parker's here, the reason Dr. Flowers is here, and all the other people that you see is because we want you to know a name. We want you to associate us with integrity. So we're not out here to exploit you, take things from you, and not give anything back. With that being said, we are at a favorite part of our program. It's give back time and getaway time. So I'm giving this back to Cornelia. Yes. Thank you so much for attending. We look forward to seeing you next month. And more importantly, we look forward to seeing you in some of our clinical research programs. There are handouts that have been distributed giving you resources for mental health and other things.
I'm going to ask Reverend Rowe, Pastor, Reverend Dr. Mr. Bo, come just close us out with a word of encouragement.
It's Pope now, actually.
Rector, Pope, Epistle,
to the
Apostle.
Archdiocese.
Yes, close us out with a word of encouragement and in prayer, and then we're going to do a little bit more housekeeping. I know we're over time. We do our best to stay on time, but not able to. I apologize, but we got some good stuff for you, so just hang tight.
All right. I won't be long. So beside every problem, there's a possibility. All right. Say that. Beside every problem, say it with your chest. Beside every problem, there's a possibility. You know why you don't recognize it? You see it. You see both of them. If a problem is there, possibility is there too. And you see it, but you don't recognize what it is. Rebel Brown wrote this book. It's called The Influential Leader. And in the book, 11 million bits of information comes to your mind every second. It's crazy, right? 11 million bits of information come to your subconscious mind every second. Do you know what comes from your subconscious mind to your conscious mind? Meaning you can recognize what it is. How many bits out of 11 million bits? Real quick, how many would you think it would be? Two bits. That's deep. Okay. How many? Five bits. Wow, you guys are a tough crowd. Okay, one more. 127 bits. Out of 11 million bits of information that comes to your subconscious mind that you see every day, you only recognize 127 bits per second. You know what? Because you have not told yourself to recognize it. You have told yourself many times to recognize the problem and not the possibility. It happened to me. Something happened when I was young, man. I don't get into that, but something happened. And I told myself, hey, I'm never going to cry again because it doesn't help. And for 20 plus years, I never shed a tear, ever. But what happened was I severed my heart from my head. I told myself that it was not safe to feel. You know how crazy it is to go through your life trying to feel with your head? It doesn't make sense. You're analytical, you're logical, and sometimes you don't know how to connect with people. So I'm saying to you today that you guys are incredible. You're amazing. You are the answer to somebody's problem. You're a miracle sitting in here today going somewhere to happen. You came here today to happen, but you got to see it. You got to recognize it. You got to recognize that you are the answer. And it's hard to say that because a lot of times we humble, but I'm the answer. You believe that? Say it then. Say it with your chest. You're the answer. You're the answer to many cases, Alzheimer's disease. And if we don't step up and allow ourselves to feel, allow ourselves to become empathetic, then a lot of times we just let stuff pass us by. But because we are the answer, because we are as somebody said, the unicorn, and because we're the prize, wherever we show up, we make a difference in everything, whether it's sports, whether it's relationships, it doesn't matter. We show up, we make a difference. So who's the answer? Who's the miracle? Who the ticket? Who handsome? Somebody didn't say it with confidence, but I get it. I believe in y'all. I love y'all, man. And so stop seeing so much of the problem. Understand that if the problem is there, the possibility is there as well, and you can be just fine. I love y'all.
Amen.